I am just so pleased that we have a very significant turnout today with over 120 people signed up to be with us. It'll take a while for them all to join, but I want to welcome everyone to our 310th Right Care Initiative Virtual University of Best Practices. Actually, many of our meetings have been in person, which is how we were able to build this collaborative over the last 15 years. And it is hard to believe that many of us have known each other that long. Dr. Mike Dolan will be our keynote speaker today. And I think this might be his 5th time presenting. He's presented to our Sacramento group, to our Los Angeles group, and I want to thank Bob Trine for introducing Dr. Dolan to us from Gundersen Healthcare. And I want to just extend a particular welcome back to 2 of our physician leaders, Jose Alberto Arevalo from Sutter Healthcare, our founding co-chair of our Capital Region group, along with Jean Shadad-Puri, who joins us from Dubai today. I also want to thank our wonderful leadership from now around the country. Dr. Dolan has joined our technical expert group. Thank you, Dr. Dolan, for that. And I want to thank our sponsors that make it possible for us to continue gathering virtually despite all the COVID complications over the last couple of years. Glad to see all of you still standing with us. We are housed at UC Berkeley School of Public Health, Center for Health Outcomes and Innovation Research. And we have a very rich collaborative with multiple public health agencies, California Department of Public Health, the Los Angeles Department of Public Health. Many of our biopharmaceutical partners have been with us for many years. And I just want to say that without them, I don't think we would have gotten through the pandemic so well, and we're just so grateful to them. Next slide, please. Most of you know me. I've been leading this collaborative for 15 years now, and you can go to the next slide, please. What we do is we drive quality improvement through providing data for medical groups and health systems to understand where they stand relative to their competitors. And in this particular collaborative, we compete against disease and not each other. So this data is really to help us understand the relative situation. And I want to say that Dr. Mike Dolan, when he came to us first in Sacramento, was able to show us as one of the top performing health systems in the country for hypertension and many other metrics, the way they use data to drive quality improvement, including through their compensation system based on the performance data. Next slide, please. We have synthesized a lot of our best practices here in the Right Care Triangle of promising interventions. And I'd have to say that the main way that we have really driven quality improvement is through provider activation, and we activate the providers with great intellectual food like what we're going to be receiving today. Next slide, please. And I want to introduce you to our wonderful statewide chairman, Dr. William J. Balmer, who's trained many of the cardiologists in the state of California, is active in providing care at UC Davis Medical Center, a cardiology leader, extremely famous in our state, and now leading not only the Right Care Initiative University Best Practices component of our work, but also I nominated him to be the chairman of the state task force on cardiovascular disease to create a comprehensive plan for quality improvement in the prevention and better management of heart attacks and strokes over the next decade. So thank you, Bill. Next slide, please. Take it away, Bill.
Well, thank you very much for that introduction, and thank you for all that you do for the Right Care initiatives and literally the patients that we have throughout the state of California, as well as nationally at this point in time. So we are delighted today to talk about an item that we have spent a little bit of time on, and that is hypertension control, and as well as insights into coronary calcium. And we're delighted to have Mike Dolan here to present that material for us today. So this is going to be an exciting presentation that we have, followed up by some interesting use of pharmacy techs as community health workers to manage hypertension. Think of it as we're still focusing on hypertension. It's probably the number one thing that we can do to reduce cardiovascular events. We have the most bang for our buck as we go there. And we're always interested in new and innovative ways of trying to control that blood pressure as we go on. And we'll see that with our pharmacy presentation later today. Next slide. So I'm delighted to introduce Mike Dolan, who we have had, as Hattie mentioned, several times before for Right Care. We had a great conversation, I think in the middle of July, when we were talking about different techniques, and we actually have tried to adopt some of his techniques here at UC Davis in our health system. But Mike is the Executive Vice President and Chief Medical Officer of Gundersen Health Systems, which is an extremely large system. And as you can see, as the Executive Vice President and Chief Medical Officer, he is in charge and responsible for almost everything at Gundersen, including multiple departments, which he has, in fact, gotten through. But the important thing is not is that he oversees all these departments and has responsibility, but he has introduced a number of innovative ways of improving their outcomes, which he is going to discuss today related to hypertension for that. So he has a lot of accomplishments, well recognized by the organizations and professional organizations that he's involved with, including being listed as Internist of the Year and a number of as Distinguished Internist of the Year for the Wisconsin chapter and other groups as well. So he is literally a leader in Wisconsin, but throughout the country in innovative ways of improving healthcare. And today is going to focus on hypertension. He completed his internal medicine residency at Gundersen's graduate medical education program. And he is board certified, as you can see, and completed a fellowship in healthcare management as well from that. He graduated from the University of Wisconsin, La Crosse, did his undergraduate at Lawrence University, both of which I should mention are in Wisconsin. So he is Wisconsin trained and educated. And today he is going to give us the approach that they use at Gundersen, and he's going to finalize it with the approach of using that same innovative technique to help the Green Bay Packers win their very next game. So, Mike, it's great to have you here today.
Thank you a lot, Dr. Baumer. Thank you, Hattie, for inviting me to speak again. Hopefully everyone can hear me pretty well. The microphone is right above my head, so I can't fault the setup of the room that I'm in. So I'm going to go ahead and share my screen. I don't know that there's anything that I can do. Where's my presentation? Disappeared.
Take your time, you're all right. We're just so happy that you're here with us and appreciate that you're also going to be giving practical tips on how you incorporate the use of coronary calcium into your practice. So what we see on the screen right now, there we go.
Got it?
Good stuff. Yes,
Okay.
now we're at your presentation.
Okay.
Perfect,
so,
thank you.
Hopefully that looks a little better. So I like to consider myself a good primary care internal medicine physician. I've just been lucky enough to be put in the position where I can lead really strong, innovative teams that have allowed us to do some incredible things here to try and improve the care of our patients. As you'll see in my case studies, it doesn't always translate into great patient care, but I doubt that anyone is able to provide perfect care 100% of the time. So when you don't do it, it's important and incumbent upon you as a clinician to learn from it and make your system better. So I'm going to talk a little bit about the objectives for today. So the first thing is I really want people to walk away with a pretty good idea of the system strategies that have been demonstrated to improve the identification of patients with hypertension. That was one of the key premises that Hattie really wanted to pick my brain about, which is, are we doing anything to try to identify people who have hypertension before they are before they have a diagnosis of hypertension on their chart? The second thing is to talk about some of the key components of a disease management program that improve hypertension control, and then talk a little bit about how we use coronary artery calcium scores in primary care. And one of the things that I've done since the last time I talked is really trying to educate our own primary care clinicians as well as our internal medicine and family medicine residents on how to utilize this really important test that I just had a meeting this week with the CEO of Quartz, which is the big healthcare system that Gundersen Health System and the University of Wisconsin co-own, along with Advocate Aurora in the state of Wisconsin, and about how we might be able to get insurance coverage for coronary artery calcium CT scores built into part of their insurance plans. Well, it remains to be seen, but I was very hopeful after that meeting. So a little reminder about where we are. Gundersen Health System is in La Crosse, which is right on the Mississippi River. It is definitely autumn here. It's about 58 degrees with gray skies and a wind of about 15 miles an hour, typical fall weather. We are surrounded by a variety of pretty well-known large healthcare systems, including, of course, the Gorilla, Mayo Clinic, as well as Advocate Aurora, which is based out of Milwaukee and Chicago. And if you haven't heard, Dolan Health, which is a large system, not quite as large as Gundersen, and located in Green Bay, Wisconsin. They are the healthcare providers for the Green Bay Packers. Dolan and Gundersen announced a merger approximately 2.5 to 3 months ago. The agreements have been signed, it's been submitted to the government, and we're awaiting approval to move ahead with the merger. So as the designated chief clinical officer for that merged organization, there's a lot going on here related to that. So that's a little bit about Gundersen and where we are. This is actually something that many of you have probably seen, which is the Commonwealth Funds report. This is from 2016, and this basically evaluates local health system performance across many different domains, and then this is the overall ranking of those healthcare regions. And as you can see, La Crosse is listed as number 15 on that list, with Green Bay listed at number 19. Dolan provides a great deal of primary care for that population as well. So our system will be pretty well represented on this list going forward. It's a very interesting report. If you have not read it, I encourage you to read it. Of course, number one is Honolulu, Hawaii, which would not be a bad place to spend some time. So one of the things that is unique in Wisconsin is Wisconsin Collaborative for Healthcare Quality. This is something that we've talked about in the past, but it was one of the very first statewide organizations to look at healthcare quality and publicly report that quality on its website. So this was actually founded by a group of people, including our former Chief Executive Officer, Jeff Thompson, along with industry partners, as well as partners in private industry, who wanted a scorecard that would allow the public to look at quality metrics to determine where the best healthcare was being provided. It currently includes 35 health systems, 325 medical clinics, and about 150 dental providers within the state of Wisconsin. So it's a pretty comprehensive source of data. And while not real time, the most recent data was actually published earlier this year after the first quarter, and reflects all of the data for 2021. And as you can see, this is basically a table that shows some of the systems that are represented and their performance for hypertension control for all patients within their system. And you can see that Gundersen is down here at about 83.9% for overall blood pressure control. And that is relatively stable for the last year or so. The other nice thing about this data, this website, is that the data is historical. So you can actually go back by clinic and look at the data as far back as the origin of the Wisconsin Collaborative for Healthcare, which was in 2004, towards the end of 2004. And you can see that our blood pressure control at that time was approximately 54% for all patients with hypertension. And that was about 18 months after we had started a disease management program, which I led for about 14 years. And you can see that over the next approximately 9 to 10 years, we slowly worked our way up to about 80% control. Things were really pretty stable, inching up about 0.5% every year until 2020, when this thing called COVID hit, at which point patients stopped coming to the clinic. Their blood pressures were not managed as well as had been done previously when they were being seen. And so we dropped down a little bit, and now we're slowly working our way back from that dip from COVID. Blood pressure control is still not great across the United States. In the first study published in 2020, that showed that blood pressure control had peaked at around 53.8% in 2014. And then since then, with the culmination in 2018 of their data set, it had dropped dramatically to about 43.7% of all people with a diagnosis of hypertension having it under control. And I would point out that that was pre-COVID. And so if other organizations are seeing what we saw in the pandemic, then it could be that our blood pressure control as a country is probably less than 43%, which it was in 2018. So I've used this saying in a lot of my talks that relate to clinical inertia. And I love it. It's actually it's a line from a book written by Amish Tripathi, who's a best-selling Indian author, sometimes referred to as the Indian Tolkien. But basically what it says is that standing by and doing nothing while a sin is committed is as bad as committing the sin itself. And so you're going to hear a story that is a true story. It's a story that plays itself out over and over again throughout our country. And it's a story that doesn't really have to happen if we, as healthcare clinicians and policymakers and leaders, do not stand idly by and watch. So this was a gentleman who I was introduced to approximately 12 years after this initial interaction with our healthcare system. At that time, he was a young man, 35 years old, recently moved to the area. He was seen in our urgent care with sinus pain and a headache, which had been present for approximately a week. He was on no medicines. His exam was really pretty unremarkable, except for one interesting thing, and that was his blood pressure. His blood pressure was elevated to 158/93. And when the nurse rechecked it a little while later, they found it to still be elevated at 126/96 with isolated diastolic hypertension. He was treated with amoxicillin for 10 days, and it was recommended that he follow up in internal medicine or family practice, if not improving, not for his blood pressure, but to make sure that his sinus infection had improved.
Sorry to interrupt you, Mike, but I just have a little teeny question to help our audience come along with you.
Sure.
So what you see there is the diastolic didn't come down like the systolic did. Can you teach us anything about that? Is there any meaning related to pain, for instance?
One of the things I talk to the residents about is that I think that pain and anxiety can definitely raise your blood pressure. But I always hate to attribute it to just that, which is why I think rechecking the blood pressure is so vitally important. And then also rechecking that when they're done with their acute episode. So if I'm going to attribute it to hypertension or to pain or anxiety, I want proof that it went back to normal at some point after that event. In this case, no one asked for proof. No one looked into it. No one followed up with the patient. So definitely, I think if you see a diastolic that is elevated while the systolic comes down as a patient's anxiety level goes down, there's no question those of us in white coats are anxiety producing. But if you don't see that diastolic go down, it definitely raises a question in my mind about whether or not that patient's elevated blood pressure was just related to pain and anxiety. So 2 years later, he came back in to urgent care, seen for a sore throat of 2 days duration, was not in a great deal of distress. Again, his exam was pretty unremarkable, other than he did have what appeared to be strep throat. Culture was positive. And his blood pressure again was elevated at 134/101. It was repeated again later in that visit and was still elevated. And again, they advised that he follow up in the clinic if his symptoms worsen, but really no follow-up at all for his elevated blood pressure reading. So 4 years went by. He's now 41 years of age, and he comes in to establish with a family medicine physician because of borderline high blood pressures. So he told this physician that his blood pressure had been described as borderline since he was in high school. And he recently had a life insurance exam, and after 3 readings, his blood pressure in his home was 135/95. He was on no medications. He had never had surgery or been hospitalized. His family history was negative for hypertension, and his social history was remarkable for 1 cigar weekly and 1 pot of coffee daily. On exam, he was overweight, BMI was 30.2. His blood pressure, when initially checked in the office, was 160/112. And later in the visit, it was 140/100. And his exam was otherwise normal. The physician who saw him actually left a rather detailed description of their conversation in the chart, which I think in hindsight somewhat comes back to haunt him, but basically described that the patient's blood pressure is definitely elevated, and it is to the point where it would be concerning. He is not interested in going on medications at this time. I did talk with him about starting a diuretic, but explained that waiting a month or so would not be inappropriate. At this point, we have 2 recent times when his blood pressure has been elevated, and certainly this is a 3rd time would be appropriate. In the meantime, he is interested in decreasing his caffeine intake and trying to get more exercise. I would like to see him back in about 1 month and see how these efforts are going, and we can determine whether starting medications at that time would be necessary. However, nowhere in the chart did he actually put in a diagnosis of hypertension. Unfortunately, the patient never returned for follow-up. So this brings up this struggle that I think a lot of primary care clinicians have, which is choosing the easier path versus choosing the more difficult path. There's no question that telling the patient to come back and see me in a month or 6 months is an easier path, and that telling the patient that we need to start a medication and explaining the rationale behind that move, as well as reviewing the potential side effects of a drug, writing out or sending a new prescription to the pharmacy, all the while trying to convince the patient that there's something that needs to be changed, is a lot harder than just saying, we'll see you back. And sometimes it's important to remind yourself that you are trying to prevent strokes, heart attacks, and kidney damage. And if the patient is resistant, you need to say that out loud and say, we are trying to prevent strokes, heart attacks, and kidney damage to the patient. So 2 more years go by. The patient is now 43 years of age, and he's seen in urgent care for ear pain. His initial blood pressure reading in the urgent care clinic was 176/128, obviously very elevated, and his repeat blood pressure was 195/136. It did not go down. He obviously had a source of pain. His TM was red, his tympanic membrane was red. It looked like there might be a possible rupture. He was started on antibiotics and some drops and given some Lortab for pain control, and he was then referred to otolaryngology. However, and here's the documentation from that clinician, nursing documented persistent elevation of severe blood pressure. I have offered pain medication injection to see if this would improve with better pain control, and he declines. I've emphasized with him the importance of having this recheck after his pain level improves and he expresses understanding. However, it wasn't important enough to actually set him up to see somebody for follow-up of his hypertension. So no referral for blood pressure follow-up was made, even though he was set up to see an otolaryngologist. In November of 2016 was a night that I actually got to meet Pete and his wife. He was 47 years of age at that time. When he went to bed that night, he felt fine, but his wife woke up in the middle of the night because she heard him fall onto the floor. She noted that when she got up to check on him, he couldn't stand up and his right side appeared to be paralyzed. He was brought emergently to the ER by ambulance, and on arrival, his blood pressure was quite elevated at 216/160. He was taken immediately to the CT scanner where these images were obtained. These are unenhanced images, so this is a CAT scan of the brain that was obtained without any IV contrast. And when you see white in the brain tissue without IV contrast, that is almost always blood. And so he was diagnosed with a hemorrhagic stroke. The radiologist agreed hyperdense acute hemorrhage with hematoma in the left basal ganglia, measuring about 3 centimeters. Acute hemorrhage near completely fills the left lateral ventricle with some extension into the anterior horn of the right, as well into the 3rd and 4th ventricles. This is a pretty significant hemorrhage in a really key area for motor control. On admission, when we first saw Pete, Pete was aphasic, which means he was unable to actually speak, and he could also not move his right side. Over the next few days, while Pete was in the hospital, he really showed minimal improvement. I love this note only because it was written by one of our social workers, and it described really where Pete and his family were at in regards to the impact on their life. Pete was a lawyer, and he was the sole source of income. And when the social worker talked to Pete's wife, Lisa, she was extremely overwhelmed. She was trying to figure out how to close his practice. And when she looked at their money situation, they only had enough money to really go about 2 more months. Their home was not wheelchair accessible, and she was not sure how she could provide 24/7 care for him. They were in the process of signing up for Badger Care, which was a low-income health insurance plan available in the state of Wisconsin. Because he was unable to tolerate 3 hours of therapy, which is the bar that you need to hit to do inpatient rehab, it was not felt that he was actually at a point where he could do inpatient rehab. And so he was subsequently discharged to a skilled nursing facility where he lived for the next 3 months, working hard. And I can remember actually seeing a Facebook post when he took his first step about 1 month after we discharged him. And that was a pretty exciting moment for he and his family. After 3 months, he was then admitted to our rehab unit, and where he stayed for approximately 4 weeks. I actually got to see him while he was there, and his speech was improving, and his activity level was improving. However, 6 years later, Pete remains on partial disability. He does practice part-time, but he has been pretty limited in regards to his activity level compared to his pre-stroke level of activity. So what can we learn from Pete's story? Number one, Pete never had a diagnosis of hypertension on his problem list, despite the fact that one could have actually said he had hypertension back 11 to 12 years prior to his stroke. Therefore, he was not in a hypertension registry, and no one was paying attention to his care. So we've had a lot of things that we put into place to help people like Pete when they have a diagnosis of hypertension. But I think one of the weak areas is our ability to diagnose and label people with hypertension when it's very clear to everyone, I think, that this is a guy who had hypertension from many years prior to that. So what's old, these are things that you've heard about in previous talks that I've given to the Right Care Initiative, but we have metrics for all of our disease management programs. I believe we have 9 of them that are currently in place, including hypertension, ischemic vascular disease, chronic kidney disease, diabetes, congestive heart failure, COPD, depression, anticoagulation, as well as chronic pain with opioid use. And we also have multiple preventive care measures, including breast cancer screening, colon cancer screening, and depression, to name a few. This is a tab within our Epic EMR that I can click on and see where I am at on any given day. It is real-time data. And so this was a picture that I took last week and shows you where I'm doing well, the green, where I'm doing okay, the yellow, and where I'm doing poorly, the red. So it's color coded. It makes it very easy in one glance to look at the areas where you might not be doing as well as you would hope to be doing. The other thing that's old is our hypertension management cards. We give these to all new primary care clinicians, all of our family medicine and internal medicine residents. It is an incredibly simple and easy tool developed by one of our vascular medicine specialists, Dr. John Zlabek, that makes it absolutely foolproof for a primary care clinician to manage even some of the more complicated hypertension patients that you run into. It was a brilliant idea, and we've utilized it for other things besides hypertension as well.
So Mike, I have to say that when I read your slides and I saw that your dashboard and your wonderful hypertension card, you had labeled old, I thought, oh no, but these things work. And so those are really oldie but goodies, right? They're not just
yeah,
old.
They are definitely oldies but goodies. The card, when I sent it, the picture is the picture. It's the best I can do with the tools I have. But if I think, Hattie, I might have sent you some cards in the past. I can definitely send you a PDF of the card front and back so that you can share that with other people. It's just a simple, outstanding little tool that I will tell you our residents love it probably more than our staff clinicians. So what's new is almost all of our primary care compensation, well, I'm going to say all of our primary care compensation plans now have metrics that play a significant role in their compensation for the coming year. And it's we typically choose some metrics that we want to look at closely. And so this is a screenshot of my priority quality metrics for 2022, which are the three that we are looking at this year are diabetes, optimal control, colorectal cancer screening, and depression screening. And you can see that my diabetes optimal control, that means all measures are controlled. We have 7 measures that we have to hit, was at 71%. This is real time because the week before this picture was taken, I was at 73%. So I had some patients that were not 100% controlled. 95% of my patients have had colon cancer screening, and 96% have had screening for depression within the past 12 months. So that's a pretty significant way for people to track their progress and to know how they might get paid or might not get paid in the coming year. We also have a search feature that we've added to Epic, which allows us to run reports to identify any patients that are not meeting goals. So for my hypertension patients, I can print a list of those who are not meeting goal and what their last blood pressure reading was and where it was obtained. The other interesting thing that we've started doing about 5 years ago or 4 years ago is we send clinicians, primary care clinicians, a quarterly report that identifies those patients that are missing the diabetes all or none measure by just one metric. So if they only got that one more thing controlled, that patient would now meet all or none criteria. And I'll tell you, that is just, it is the low-hanging fruit because it takes very little effort to work on one metric, let's say smoking cessation or statin use, whatever. And it allows the clinician to target interventions that increase the likelihood of getting that patient to the all or none goal. Another thing that's new in our clinics is it is mandatory now that we repeat a blood pressure on any patient whose blood pressure exceeds 140 systolic or 90 diastolic. And that is irrespective of whether or not they have hypertension. And our goal is to do that 80% of the time. And you can see most of the time in our clinic, this is just the internal medicine clinic, we do pretty well, but the week that I took this snapshot, you can see we dipped below the target for only the second time over the last year. And so it's important, and when you miss repeating it, you get an email at the end of the week that says you missed this opportunity to recheck the blood pressure. And if they don't have a diagnosis of hypertension, you're also notified that this patient does not have a diagnosis of hypertension on their medical record. And so it just is a reminder that maybe you need to do better. And lastly, in the what's new is, and it really came out of the specialty clinics, or it came out of our primary care clinicians being really upset about the fact that patients were being seen in specialty clinics and were having elevated blood pressures that they were not made aware of, which then impacted their ability to control the patient as well as their compensation. And so we now require specialty clinics to notify the primary care clinician of any patient whose blood pressure is elevated above 140/90 when they are seen in that subspecialty clinic, which then allows them to develop a plan to address that patient. One of the last things that I would say is that it's been very interesting with the pandemic in that we are now really utilizing virtual care significantly differently than we have in the past. And this is actually a positive. We're doing a lot of virtual visits, which then incorporate remote blood pressure monitoring that is done by the patient. There are actually interesting case studies out there that look at this and show the improvement. And you can see this was one product. It's a management product that you can purchase for your clinic, and improved the blood pressure control to 80% after just, I believe it was 28 days cycle. So there's some really interesting stuff. We now, in the WCHQ data, allow clinics to utilize virtual data that is uploaded into their EMR from patients. And patients really appreciate that. They appreciate virtual visits and the ability to not have to travel, especially with the cost of gas. And a lot of our patients travel a pretty significant distance to get here, since some of our clinics are 30 and 45 minutes away from La Crosse. And interestingly, our patient experience scores for virtual visits are actually 2 to 3% higher than for patients that are seen in person. So that's just a brief snapshot of some of the things going on with hypertension at Gundersen. And then I thought I'd talk a little bit about the emerging role of coronary artery calcium CT scans. And again, I'm going to base this around a patient. This was a 50-year-old male who wife told him he needed to get a physical since he turned 50. He hadn't seen a doctor in 10 years, but he's relatively healthy, takes no medicines, doesn't smoke, has had no previous surgeries or hospitalizations, no family history of premature coronary artery disease, and he has really no significant concerns. In fact, he wouldn't be there if his wife had not made the appointment for him to be seen. On exams, blood pressure is elevated, 135/80. His BMI is elevated to 32, but his exam is otherwise pretty normal. His screening labs show a mildly elevated glucose of 102. His cholesterol, pretty typical cholesterol profile around here. Total cholesterol 225, HDL 40, LDL 140, triglycerides 220. And so the question is would you treat his cholesterol? Would you treat his blood pressure? And would you have him start aspirin? So in questions like this, there's always the balance between benefit and risk. And so the benefit, prevention of stroke and heart attack, longer life, decreased morbidity and mortality. The risk, of course, is cost, maybe cost that doesn't have any long-term benefit for the patient, side effects of medication, and the patient's comfort with taking medication. There's a really, actually, I consider it a disturbing study because it showed that up to 8% of patients are willing to forego taking medication to prevent coronary artery disease and coronary events for up to 2 years of extended life. So 8%, 1 in 11 approximately, will avoid taking medication, even though they know that it will increase their longevity and help them avoid a coronary event. And 21%, 1 in 5, would trade between 1 week and 1 year to avoid taking a medication. So that's what we're dealing with in the clinic all of the time. The other problem is who do you listen to, and who do you listen to? Because there are a lot of guidelines out there. There are the American College of Cardiology guidelines. There's the U.S. Preventative Task Force guidelines. There's the U.S. Department of VA guidelines, the National Lipid Association. There are many, many different guidelines, and none of them really say exactly the same thing. Here's something from the National Lipid Association guidelines, and you can see that a lot of this is based around the level of LDL and non-HDL cholesterol based on other risk factors that the patient might have. And for a lot of primary care clinicians who are in a busy practice trying to see patients every 10 to 15 minutes, to go through this every time can be somewhat time consuming. There are other guidelines. There are the Canadian Cardiovascular Society guidelines. There are the European guidelines, the ATP3 recommendations. So what I tell the residents is that you just need to relax and pick one and then follow it. Base your practice on that one guideline that you believe is the best way to take care of your patients. And what you pick might be different than what I pick. And so it's just important that you stick with one and be comfortable with it and understand what it is that you're doing for the patient. What do they have in common? Well, they all endorse the use of statins for primary prevention, and they're generally risk-based rather than targeting specific LDL levels, although some do highlight specific LDL levels, but a lot of them have incorporated risk as part of that. So back to our patient, what do the guidelines say about treating his cholesterol? Well, the ACC guidelines would say consider treatment. He's between 5 and 7.5%. U.S. Preventative Services Task Force says no, don't treat. USDA, no, don't treat. National Lipid Association, no, don't treat. But what if this is the patient's coronary artery calcium CT scan? So here's a picture of a patient of mine who got a coronary artery calcium CT scan. He was 65 years of age. He refused to go on a statin, even though his cardiac risk over the next 10 years was 10%. And what you can see at the tip of the red arrow there is a pretty significant amount of coronary calcium in his left anterior descending coronary artery. His coronary artery calcium CT score was actually well over 400. And on catheterization, he was found to have a 95% proximal LAD lesion that was rather dramatic. And so coronary artery calcium CT scoring has been around for a while. Every study that I have looked at that it pertains to coronary artery calcium CT score has considered it the superior marker for reclassification of risk. There was one study that looked at 7 different measures, and coronary artery calcium CT score won by a long shot. It's a non-contrast CT equal to about 3 chest x-rays of radiation. The score is basically the Eggleston score, which is density times area. It's a computer-derived score, and an elevated CAC score is a strong predictor of future events. And up to 50% of patients may have their risk reclassified up or down by coronary artery calcium CT testing. And so it is a really useful tool. Who should consider getting a CAC score? First, patients who are in that 5 to 20% risk, where the benefit of statin initiation or intensification remains uncertain. Patients who have a 10-year risk less than 5%, but have an elevated risk due to a factor that is not accounted for in the global risk equations. And lastly, patients in whom statin therapy is clearly indicated, but they are reluctant to take a medication, and I utilize it to try and convince them to take it. One of the drawbacks to CAC scores is that it is usually not covered by insurance. We have mitigated that by making a $225 out-of-pocket cost. So essentially a copay cost for a CT scan that typically is thousands of dollars. The CAC score is actually determined by our cardiologist that looks at the scan, and then the scan is actually overread by one of our radiologists to look at the mediastinal and pulmonary findings, and the patient then gets a combined report. I tell my patients when I'm trying to encourage them to have this done, that it is the best bargain in healthcare that they will spend $225 for. I put together this algorithm mostly for our residents. It starts with assessing the patient's 10-year risk. If their risk is greater than 7.5%, I usually encourage them to go on statin therapy. If the patient refuses, I offer them a coronary artery calcium CT scan. If that score is 0, then they can elect not to be treated. If that score is anything but 0, then I recommend that they get treated. And I believe my treatment rate for those patients is about 90+%. If their score is intermediate, 5 to 7.4%, I offer a CT coronary artery calcium score. And again, if 0, no treatment. If greater than 0, that's great. If their risk is less than 5% and they have no additional risk concerns that are not accounted for in the risk scoring tool, then they don't need treatment. If they do have an unaccounted risk factor, then I offer a coronary artery calcium CT score, and again, follow the algorithm after that. What if this patient is that 50-year-old, and it turns out that 2 years ago, he had a CT scan of his abdomen and pelvis for evaluation of abdominal pain in the emergency room, and his aorta looks like this. Well, that's just something that we looked at approximately 14, 15 years ago now. But it was really a proof of concept study, pretty small scale, 100 patients. We looked at all patients that had had a cardiac catheterization done in 2007, and then those that had had a preceding CT scan of the chest, abdomen, or pelvis in the 5 years prior to the cardiac catheterization. And what we showed, if you attended the last talk that I gave, what we showed in that study was that if you had no aortic calcification, there's a 3 out of 4 chance that you had 0 coronary artery disease. And remember, these are patients that are getting catheterized because they are having symptoms. If you had any aortic calcification, there is a 62% chance that you had significant coronary disease. And if you had severe aortic calcification, there's a 62% chance that you had multi-vessel coronary artery disease. So how does that translate into the real world? Well, this was a patient that we actually admitted to the hospital with chest pain while shoveling snow. 64 years of age, he had multiple risk factors. He was hypertensive, diabetic, not a smoker. His Framingham risk score was 18.4%. And despite that being significantly elevated, he was not on statin therapy. We couldn't find in the chart that he'd actually ever been offered statin therapy. Interestingly, he had had a CT scan of the abdomen and pelvis 2 years earlier, which you saw in that scan of the aorta. And but what I didn't show you is that this is the very first image from that CT scan, which tends to catch the bottom of the heart. And what you can see right here is his LAD, and it's pretty heavily calcified. And and of course you saw what his aorta looked like down below. And when he had his cardiac catheterization, because of the fact that he was having those symptoms, his cardiac catheterization showed severe 2-vessel coronary disease, and he went on to coronary bypass surgery. So conclusions from this: aortic calcification is readily identifiable on CT scans of the chest and abdomen, obtained for other reasons than a coronary artery calcium CT score. Aortic calcification can be a marker for increased cardiac risk, and you can use this information to convince patients of the need to be on a statin for primary prevention, thus negating to go ahead with a CAC score if you would like to avoid that. It can also be helpful to elucidate chest symptoms in patients that might be cardiac in nature if you have any prior imaging that you can demonstrate aortic calcification on that scan. So I covered a lot of ground during that short 40 minutes or so. And I just want to thank Hattie and Dr. Baumer for inviting me to speak again.
Thank you so much, Mike. That was really outstanding. And I have kind of a radical question I'd like to throw at you before handing it over to Bill Baumer. And that is, have you ever seen a malpractice case related to not catching the hypertension and treating it? I mean, if I'm in the family of the person who's going to be permanently disabled, you know, might I ask to see the medical records and see what was done? Because it just seems so strange that the prescription wasn't made, whether or not the patient decides they don't want to take the medication. And so I just wonder if that's occurring in our health systems.
I actually don't know the answer to that. That is an excellent question. I know that in this case, there was never any, and despite the fact that the patient was a lawyer, that there was never any legal action. I will say, we are blessed and fortunate, knock on wood, to live in a fairly low malpractice environment here in Wisconsin. We have caps for damages, and we also have a patient compensation fund that handles any judgments for greater than $1 million. So it's a relatively good environment for malpractice. But yeah, it's an excellent question. I do not know the answer. I'm not aware of any instance. I think if I were to defend the individual that that saw him when he actually came in with concerns about his blood pressure. They did talk about drug therapy. The patient declined drug therapy at that time. They did set up a follow-up in 1 month, but the patient never kept that appointment. And since the patient wasn't on any registry, no one actually bothered to then follow up on him in the future. Normally, if you have somebody on your hypertensive registry that you're following and you haven't seen them to record a blood pressure, after 12 months, considering if they were controlled at one point, they would then show up because they don't have a reading in the last 12 months. So that would be a big red flag that, oh man, I got to get this patient in and see them. But yeah, that's a great question. I'm sure if I do a lit search that I can probably find a case out there where somebody went back in the medical record and found evidence of untreated but diagnosable hypertension.
And I've been wondering the same thing about those incidental findings of coronary calcium. So now that we can find in our medical records easily these items, we should probably be proactively using that information that's in the computer system to offer medication therapy management, because we know what's coming for those patients. I think that's the future, is those incidental findings won't just sit there, because we'll be able to find them in the medical record and get a report. For instance, would your health system be able to create such a report of who has had incidental findings?
So one of the things that I would like to do when I'm not an administrator anymore is to do a much larger study. We have a summer fellowship program where we recruit college students who are pre-nursing, pre-medicine, and they do research for a summer. And it's amazing some of the work that gets done as far as the data collection. So I think that I have about 10 different studies I would like to do when I get to that point. But right now, my administrative job kind of takes me away from all of that, all of the other things that are going through my head day in and day out.
Well, thank you for this magnificent work. Dr. Balmer, did you have a question?
Yeah, thank you very much, Mike. I really appreciate that. Certainly going into the details on how you go from 50% up to 80% is incredible for hypertension control. I mean, we're struggling at, say, 70%. We want to bump up to 80%. That's what Million Hearts is. And that extra 10% is not easy to accomplish. So I congratulate you on that effort in your organization. I was interested in your review in the coronary calcium of the statins. And I think that your recommendation or your algorithm is pretty similar to the AHA-ACC on looking at low risk, high risk. High risk goes on statin, low risk, very low risk doesn't. And the intermediate ones are where coronary calcium can be helpful to define if you're uncertain as to what their risk is. And then that can define who goes on a statin or not. What do you do in the situation where you have a patient who is statin intolerant? In other words, in that population, has a coronary calcium score been enough for you to, in fact, authorize and get funding for a non-statin lipid therapy, which are like monoclonal antibodies, are more expensive, require a treatment authorization request to get through? Has that coronary calcium been enough to justify in an asymptomatic and in primary prevention to justify reimbursement for other therapies which are more expensive beyond statins?
I have not run across that yet. I'm pretty certain that that's coming, and now that those medications are becoming more widely available and used. It does require pretty significant and lengthy prior authorization process for our primary insurer, which is the insurance plan that we actually own with the University of Wisconsin, Madison. I will say that, you know, with statins, if someone is intolerant of one statin, I typically move to another statin. I go through all of them. Once I've gone through all of them, then I take the lowest dose and I utilize it on an interim. So basically not giving it every day, but giving it every other day, as much, whatever they can tolerate, because I think that some statin has a benefit at stabilizing any plaque, so that it's less likely to rupture. And so that's basically my algorithm for how I treat it. But I'm sure that there will be patients down the road that don't tolerate that, or in whom their coronary artery calcium CT score is so high that the likelihood of significant severe coronary disease probably warrants going to the more expensive monoclonal antibody treatment.
Do you ever use a target LDL in those patients? Try when you're using lower dose statin instead of intermediate or high dose statin. Do you have a cutoff where you would draw the line and say, this is perhaps where I would add an additional non-statin therapy? Sure.
So typically trying to get somewhere between 70 and 100 if their primary prevention. Ideally less than 70 is where I'm usually shooting for. If you're using low dose, unless they're starting at a pretty low LDL level, you're not going to get there with a low dose or an interval therapy, such as every other day dosing of rosuvastatin or atorvastatin. And then I'd add a second agent, Zetia or something.
Right, very good. Thank you for that.
Can I ask a question?
Go
Sure.
ahead.
When do you repeat a coronary calcium score? Maybe I missed it on the algorithm.
Sure.
I see that you take
Yeah.
it, but when do you do it again?
So most of the literature that I've seen on repeating CAC scores talks about a 5-year interval. So essentially every 5 years, approximately. Now, if it's positive, I mean, my goal, if it's positive, is to maximize their primary prevention. If obviously you're doing these tests in people who have not had a cardiac event. And so do you really need to recheck it in 5 years if you maximize their primary prevention? I don't repeat it in those instances, but if it's 0 and they have a reason to maybe be on a statin because of their calculated cardiovascular risk or other factors, then I would repeat it in 5 years.
Thank you.
Great. We have 2 questions on our Q&A. One is, have you ever seen a high calcium score greater than 1,000 in someone who did not have obstructive disease that is greater than 70% in that lesion? Could you get that much in the periphery of the vessel without occluding the vessel?
Very good question. So in the patients that have had a CAC score where it was over 1,000, and remember that with the way that the Eggerson scoring goes, greater than 400 is considered severe. The people that have had cardiac catheterizations, which is not all of them, because again, these are asymptomatic people who it's primary prevention. I can't think of a single one who did not have at least a single vessel, if not multiple vessels, with greater than 70% lesions. The last one that had a cardiac catheterization had multi-vessel disease with 2 vessels that were over 70% and 1 vessel at 50%. And they're on, they did not have any intervention as they were asymptomatic, and they are on primary prevention.
So it would be possible, but unlikely that
I
someone,
believe that's how I would phrase it.
that would be reasonable. And then the other thing that we see with coronary calcium is we do see it in runners or athletes who develop calcium or higher numbers in that particular situation. And there is some evidence that once you go on a statin, you may actually get a little bit more calcium deposition or showing up on the coronary scans. Is it really that important to just do one coronary calcium to assess the risk, or should there be follow-up in someone who we know already is, let's say, over 200 or 300 in their coronary calcium score?
I don't know that I've seen data that answers that question. And I like to do, I like to base what I do in clinical practice based on data that shows benefit for the patient.
And I know that that's in the calcified patient. There's probably not a lot of information in the follow-up because it's confusing. But in the individual who comes out with a coronary calcium of 0, how long a warranty do you give them at that point for not treating with statin and not worrying about coronary artery disease? Is it a 5-year warranty, a 7-year warranty, or a 10-year warranty?
I don't give warranties, but I guess if I was going to do it, I would say 5 years because that's when I would typically repeat it.
Got it. Thank you.
We have another couple of questions in the chat, and I think we see this one often. If you have a positive coronary calcium score, but otherwise have a low 10-year risk profile, then would you consider that a re-stratification and start the patient on moderate dose statin? The other one I think is too technical, whoever put the thing in about the lumen, but Bill, I'll have you make a call on that next. So if somebody has positive coronary calcium, but a low score, I think your algorithm shows that you would go to treatment.
That is correct. Yep, absolutely.
Okay, I just have in my chat box the fact that it's thanks, it's good to see you, and remember to use the Survey Monkey because we do have CME credit for today. And
we
the
can
link,
deal with that later. So there's
right.
a question that says, and I think after this one, I think we really should move to our other speakers. And Mike, I hope that you'll be able to stay with us later because we have a lot of interest in the many, many things that you've talked about. This one we might need one of our cardiologists to talk about it, but it's just what percentage of patients have high calcium score, but the calcium is outside and not in the lumen?
Well, we do know that the coronary calcium that is less severe is going to be on the periphery and in more solid areas. The ones that we've seen in intravascular ultrasound is the more speckled pattern of small microcalcium distributed throughout the plaque. Those seem to be a little higher risk of rupture, whereas an actually very calcified large plaque could potentially not rupture. The key is what's on the surface of that original plaque and what are the stresses placed on it for actually rupturing and exposing the contents of the plaque or the gruel to the blood system, and the blood system then gets activated platelets and white cells that leads to the, in fact, acute myocardial infarction event or coronary ischemia event. So I would say coronary calcium is a very effective screening device. It is not 100% predictive of an event. So if you have coronary calcium that's high, it doesn't mean you're going to have a heart attack in the next 6 months. It means that your high chance of having one is significant, especially over the next 10 years, enough for us to be worried about it. and enough to say that your either 5 or 10-year risk is high enough that you should be on treatment for prevention of atherosclerotic plaque. So nothing is 100%. And very few patients, if you look at coronary calcium, is it easy to decide if it's on the periphery of the vessel or in the vessel, because the Agatston score is not precise enough to tell us that location. The newer techniques of MRI intravascular ultrasound are better able to show us the distribution of the plaque, and they would answer that question. And on IVUS, we see sometimes it's on the periphery, sometimes it's a large chunk in the vessel, and sometimes it's minute calcium nodules distributed throughout the plaque. And those are the ones we worry about most.
And this is why I love presenting, because I learn something every time I come to Right Care Initiative.
Well, we're hoping you learn a lot, because our relationship is, you realize that Aaron Rodgers graduated from the University of California, Berkeley, which is sponsoring this program. And we were at least unwise enough to allow him to go to Green Bay to in fact lead your team. So we regret that mistake. It will not happen again.
Thank you very much.
Mike, we always love having you with us. We're going to have Cindy Jambroni, our Southern California Memorial Care System co-leader, introduce a couple of our other colleagues who will be presenting on something related to hypertension and with some really good success.
Great. Well, thank you, Hattie. So it's my pleasure to introduce 3 speakers. Steven Chen, who serves as the Associate Dean for Clinical Affairs at USC School of Pharmacy and is a clinical professor there. Jessica Abraham, who is the Director of Population Health at USC. And we also have Fabiola Barrera, who is a clinical pharmacy technician at USC. Included in the agenda is the very extensive bios from both Steve and Jessica. And I'm hoping Jessica can share more with us about Fabiola to learn more about her. Today, they're going to be talking about utilizing pharmacy technicians as community health workers to manage hypertension. But I really appreciate the opportunity to introduce these speakers, because it is through the Right Care Initiative that I have gotten to know Steve and Jessica better. And they really serve for me as mentors and advisors on all different kinds of topics, whether it be in leadership or in terms of clinical pharmacy questions, or even during the pandemic. I was looking in preparation for this call, and I can see emails between Steve and I trying to figure out how we're going to do vaccine clinics, and he's sharing with me tips that they learned in Dodger Stadium, and I never would have thought to reach out to Steve if it wasn't for the fact that I got to know him better through the Right Care Initiative. So with that, I will hand it over to the team to talk about utilizing pharmacy technicians as community health workers to manage hypertension.
Thanks, Cindy. And as you know, you're one of my favorite people to reach out to. And I'm challenged with managed care questions, so I always appreciate the collaboration. As Jessica's putting up those slides, I just have to say, Dr. Dolan, every time I hear you speak, I'm amazed at how many new things you bring. It's a brand new presentation, almost like there's a brand new person presenting. Very fresh ideas. I just texted someone that you're always quality focused, innovative, and practical. So I always appreciate having you in the programs. I also hate following you, but I'm stuck with that, unfortunately. So here's our title of our presentation. It's utilizing pharmacy technicians. And I quote that very carefully, as community health workers to manage hypertension, because I don't want to take away from the amazing, very specific work that community health workers do. This is more about how we leverage pharmacy technicians in a way that optimizes the many skills, talents that they have that I think we've been underappreciating in pharmacy practice. Thank you. This is our outline. I'm going to just do a very quick introduction and hand it off to the people that really understand this work well, Jessica Abraham and Fabiola, who is a remarkable clinical pharmacy technician. Next slide, please. So just for background, I wanted to share so that we're all level set on, what is comprehensive management, get that in the context of hypertension. And let you know up front, this is not a data heavy presentation. There isn't a lot of research or studies on clinical pharmacy technicians in this role. In fact, I think we were one of the first to start something on a larger scale. We do have a manuscript related to our work with pharmacy technicians in a clinical capacity as part of our round 1 CMMI Healthcare Innovation Award, but it hasn't been published yet. But just to start with, just so we are all level set on why we're focusing on medication management, hypertension. Some of you have seen this before. The problem when medications are not optimized is expensive at over $500 billion a year. That's lost or wasted because we don't get medications right in terms of dose selection, combinations, et cetera. Accounts for up to 3/4 of possible readmissions among seniors, at least the 4th, if not 3rd leading cause of death in the US. Just a lot of avoidable harm and an epidemic in itself when we don't get medications right. Next slide, please. And what we're trying to sort of establish as the standard of care for optimizing medications is comprehensive medication management. Again, right medication, given the vast choices available for a given indication, right dose, not so low it's ineffective, not so high that it's toxic, safe given other comorbidities, other medications, making sure patients can use the medications and related devices. Again, I share this all the time, but you'd be shocked at how perfectly you can train a patient to use a medication or related device. Bring them back in a few weeks, 6 weeks, and see what happens. They miss major steps. And then, of course, that the medications are affordable to patients. This is all wrapped up into a very close partnership with the patient's primary prescriber. There's constant communication in comprehensive medication management, or CMM. There's follow-up with the patient, and I loved all the emphasis Dr. Dolan shared on following with patients until patients reach their treatment goals. And it's, again, very collaborative in terms of the process. It's not an independent pharmacist are doing one thing that nobody else knows about. Next slide, please. And just in terms of context of where this fits, this pyramid represents the services pharmacists provide in the population health space. As you can see, going up this pyramid, you get a more rapid return on investment. You get a higher either direct cost savings or cost avoidance for payers. And if you're looking at the top 2 tiers, this is where comprehensive medication management has its greatest impact. The patients that are already high risk, high utilizers, or those that are emerging risk or about to become high utilizers. We find that this 15-20% of a given population of care is where you get very high return on investment in terms of costs, quality, patient safety, outcomes, et cetera. The other domains are not really tied to CMM. That 3rd tier going down is more the regulatory metrics. And some regulatory metrics are tied to quality. Some we're just checking the boxes, I hate to say. And then on the bottom are very important interventions in preventative health, which don't have as much of a rapid return on investment, but we know from COVID how critical these functions are. But again, I just wanted to paint a picture for you of what types of patients benefit the most from CMM. Next slide, please. And there's plenty of data, plenty of reports from non-pharmacy based organizations that highlight the value and the importance of pharmacists in the medication management space, including the one on the lower left from the CDC, specifically highlighting the role of pharmacists in hypertension management. Next slide, please. Now, just to kind of take you back a little bit, back in 2012 or so, we received that round 1 Center for Medicare and Medicaid Innovation Healthcare Innovation Award. And up to that point, I've been practicing in primary care pharmacy for about 25 years. And in every practice setting I was in, whether it was the VA, Beverly Hills, or Skid Row, I was kind of solo, right? I was the person who would contact patients, check them in, do the vitals, the point of care, run the appointment, follow appointments. I mean, I did it all, and that's not uncommon. In ambulatory care or primary care pharmacy practice, pharmacists are often solo without the equivalent of a medical assistant. And so when we got this grant, we were really excited, but really stressed out about how are we going to do this in a way that is efficient. And the bottom line is, for many of the functions I just described, I don't need a doctor of pharmacy degree, right? Whether that's soliciting patients to engage in comprehensive medication management, starting the first steps of med reconciliation. Let me highlight something here. Dr. Rita Shane over at Cedars-Sinai did some really pioneering work where she evaluated about 300 patients and compared what happens when you have a pharmacy technician versus a pharmacist versus usual care doing admission medication histories, and what's the impact on errors when it comes to admitting medication orders. And what she found remarkably is that pharmacists and technicians conducting those admitting medication histories were both equally effective at reducing medication orders upon admission, to the point where they were 80% fewer than usual care. So just again, highlighting the importance of technician in this role. Grooming patients, again, vital signs, point of care testing, helping with patient education, scheduling appointments, check-in calls, reminders, and then some of the social needs, social determinants. These are all things that we felt, well, while we do these all the time as pharmacists, we could probably train someone else to do it very well. Next slide, please. So we came up with a curriculum where we certify pharmacy technicians to become clinical pharmacy technicians with those skills you just saw on the previous page. And in an implementation pilot in our CMMI Healthcare Innovation Work Program, we did basically a rapid cycle improvement process. And in those 40 patients that we evaluated, we found that we cut the time the pharmacist spent with patients by almost a half. And it resulted in being able to see 40 to 50% more patients a day. It's remarkable efficiency compared to before. Next slide, please. And then in terms of impact on patients, in the first 45 days or so, the patient enrolled in our program with uncontrolled hypertension, within 45 days, 87% reached the then goal of less than 140/90. So we knew that working with pharmacy technicians in this program, where pharmacists were given scope of practice to manage medications for hypertension, that our results were very effective. Next slide, please. But really what was interesting to me is something that I didn't fully anticipate, and that's the impact on patients. The patients would send unsolicited letters to the clinic that we worked at, talking about how important the service was. And this is a typical letter. You don't have to read every bit of it, but it's pretty funny because patients that had never heard of working with a clinical pharmacist will first scratch their heads and think, "What? I already see a primary care doctor. Why don't I see a clinical pharmacist? I see a pharmacist at CVS." But it's once they make that first appointment, they understand the empowerment and the value of working with a pharmacist in this capacity. Next slide, please. But again, what I really appreciated was that in every one of these letters, this one being the sample, the clinical pharmacy technician was called out. And you can see the red lettering in this one. Wendy was the pharmacist in this particular letter, where this patient said that her phone call was more than she could have asked for with respect to having a trusted liaison in the program. And that theme kept coming back over and over again. Our pharmacy technicians built remarkable relationships with our patients. And in many cases, I thought they were better than what we could do with our pharmacists. So next slide, please. I think we popped out for a second. So really, that's my setup for handing it over to the people that are going to give you the sort of under the hood details about how this all works. How can we deploy pharmacy technicians in comprehensive medication management to manage hypertension and some of the other many challenges of working with underserved patients? So I'll hand it back over to Jessica Abraham. Thank you.
Right. Thank you, Steve. So I'll speak a little bit about how we actually integrated them in this program that Steve was talking about, Ultimate Clinic, and how we integrate them every day, just in different pharmacy settings, where we're growing to, evolve the technician profession, just as the pharmacist profession is growing and expanding. We're learning how to utilize them to make our work more efficient and better, really, for everyone. So for those of you that might not, regularly work with pharmacy technicians, just thinking about a little bit of background about what can they do per their license from Board of Pharmacy for California. And really it's a little vague because the language is based on a technician working in the traditional pharmacy where you're filling medications, putting the medication in the bottle, typing up the prescription, affixing the label. But in a nutshell, if you take really the essence of what Board of Pharmacy says, it's that a technician is an individual working, it says in a pharmacy, but it's really a pharmacy setting because we know now that there are many pharmacists and technicians that don't actually work in a pharmacy. And a technician is anyone who assists the pharmacist under the pharmacist's supervision in pharmacy activities that don't require professional judgment of a pharmacist. And then you'll see they further have specific responsibilities like packaging, repetitive or other non-discretionary tasks, et cetera. And these are very much examples of things you would do in an actual dispensing pharmacy. But really at the end of the day, it's really anything they can do to support the functions and responsibilities of the pharmacist under the supervision of a pharmacist and control of a pharmacist, but tasks that don't require the professional judgment of a pharmacist. And that's really the key in utilizing clinical pharmacy technicians or technicians in any pharmacy setting that you're working in is figuring out, having them work at the top of their license and the pharmacist being able to do the same. There are also some ratios. The slide's not that as important, but in terms of being that when a technician is performing more clerical roles and other roles that are not necessarily filling the medications, even the ratios in terms of it being like 2 technicians per pharmacist, even those ratios don't really apply when your technician is supporting more clerical roles, like making those appointments, that outreach, all of those kinds of tasks that we'll talk about next. So as Steve touched a little bit about this, just why technicians? And really, like I had said, it's as the pharmacy profession is growing, we have to consider expanded roles for pharmacy support staff to ensure that the services that we're providing are efficient and cost effective. And then the other reason is, just like he said, technicians are actually good at it. When we train our technicians through various programs like USC's Clinical Pharmacy Technician Certificate Program, they are able to perform the tasks that we'd like them to perform in more of a clinical setting and are able to do it very, very well. There were multiple studies that I even looked at when I was putting the slide deck together, showing that technicians were able sometimes to do it even better than pharmacists when they were doing med reconciliations and collecting the information, and other healthcare professionals. So there was a Dutch study where patients were being prepped for surgery, and it showed that pharmacy techs were better able to reduce med-related discrepancies in the record with a 5% error rate compared to anesthesiologists who had a 38% error rate. And that's just, it doesn't say that the other professions, don't do it as well, but when you have a technician who is only focused on, collecting a very detailed med rec, and then is also trained how to document that very accurately in the record, there were less errors. The same thing happened when there were studies comparing pharmacists to nurses in conducting medication histories in Florida in an emergency department, and other studies as well, where there were a decrease in potential errors due to ineligible errors, incomplete and incorrect drug information, serious drug interactions, again, reduced in this study by 82% compared to nurses. So it's taking a role and really teaching them to become an expert in a certain task. In this case, it was in medication reconciliation and med reviews, and having them not only conduct the task, but document thoroughly. And it ends up supporting really everyone on the team, whoever they were working with, whether it was anesthesiologists or nurses, so that they could then take on all the numerous tasks that they needed to do and be able to rely on a very accurate documented med rec in the EHR. And then as well, just skills that we've seen and qualities in our technicians is very, very strong communication skills, attention to detail, very self-motivated, and then they always come with education or extensive experience in a hospital or a community pharmacy setting. And that helps in just having them have that strong medication background with respect to drug names, doses, side effects, those things that they're able to kind of easily hone in when they're speaking to patients and collecting information. So this little diagram just shows you some of the benefits. Some of them we spoke about, others are here for your attention, such as that our technicians really become super users. So they become super users of platforms that we use, of the workflows, of the processes, and then they become people that we can, that really stand in our team to train others. They train our pharmacist interns when they come on board, new residents as they rotate through, because they've seen the whole picture. They work hand in hand with the pharmacist. So they really know from the very beginning of like patient recruitment and marketing of a program and why it's important, to the very end where you're discharging a patient and managing the programs that we have that we'll talk about a little later, of monitoring programs that make sure patients who graduate from our programs and have met goal actually remain at goal. And then you saw increased efficiency. Steve mentioned this, increased outreach. If, you know, in a lot of our programs, if the pharmacist was doing it all, there is no way we could get through the lists of thousands of eligible patients that need to be outreached to and spoken to about the clinical pharmacy program to improve their blood pressure, why it's important to improve blood pressure, why getting their blood pressure under control is, you know, an important thing in their life right now. And our technicians are trained actually also with a lot of motivational interviewing skills and good communication skills that they're able to keep those patients on the phone many times better than our pharmacists can. They're culturally sensitive to those patients, most times culturally aligned with the patients they're speaking to, and can hone in on the importance of, you know, taking control. More CMM ambassadors, that's another piece. When we worked in the clinic setting, our technicians became kind of CMM promoters, and they knew about, you know, the importance of our program. They were friends with the medical assistants and other workers like community health workers like promotoras, and everyone kind of learned from them what a clinical pharmacy program, for example, managing hypertension was all about. And they could all identify patients, aside from the patients being referred by an MD or a different kind of PCP to the service, they were able to identify patients as well that could benefit from the program. And then improved satisfaction, of course, that's job satisfaction for technicians and pharmacists, but even patient satisfaction that you saw in the previous letters that Dr. Chen had honed in on. And then increased learning, where, you know, the technicians and pharmacists are kind of learning from each other. There's things that I would see and notice that the technician is counseling, is, you know, reaffirming the education with the patient, maybe talking about certain things about the diet that I might have not noticed, or exercise that I might have not noticed the patient was having trouble with or not. So there was always this collaboration and, you know, of how to best treat these patients between the pharmacists and techs. And then skill expansion, of course, for both pharmacists and technicians, and consistency. Many times, a lot of pharmacy programs, I would say, a common theme is, you know, residents coming in and out, pharmacist interns coming in and out. So new faces, different faces. And a lot of times patients really just appreciated seeing one person that's always there, that's the same person that calls them on the phone, same person that greets them when they come. So that added bonus was a nice part by having, you know, a clinical pharmacy technician dedicated to this. So in comprehensive med management, we kind of have like four of these steps that we go through with all of these patients to control their blood pressure or really do anything, whether it's diabetes, asthma, any other chronic disease states. And in these steps, we'll talk about each one just a little bit. You'll see how we integrate our clinical pharmacy technicians and where they're able to kind of support many of these tasks that go into taking care of these patients and getting their blood pressure controlled. So you see over here, we start with patient assessment. And I think the key is to realize it's not really assessment of the medical condition. This step is really collecting information, collecting subjective and objective information from the patient. And the technicians are heavily involved here. Versus number two, evaluation of medication therapy. This is where it's really primarily the pharmacist pharmacist or residents or pharmacist interns that are coming up with the assessment and plan for the patients. And then number 3, developing that plan, carrying out that plan, educating, and then 4 is the follow-up and medication monitoring. So I kind of just broke up the various tasks of each of those steps to kind of give you an idea of how much we can use our technicians in CMM to control blood pressure. So in that first step, where we're reviewing the medical condition using subjective and objective information, and it's really just obtaining and documenting a complete med history. A lot of times you're looking in different medical records, you're requesting things to get faxed from a PCP office if you're not already integrated in the clinic where the PCP is. You're requesting things from the endocrinologist or the cardiologist or whatever it may be. And again, the technician is vital in doing a lot of that research and collecting of information. And even if it's an initial visit, again, collecting that information, asking the patient what drugs they're taking and how they're taking them, and asking them for their blood pressure measurements, and really all of that collection of information. So of course, pharmacist intern can do all of them, but then the technician can actually help with all of these steps as well. Here, this is really that step that I was saying is really where you're assessing appropriateness of the current medication regimen and evaluating effectiveness of the therapies. So those first 2 steps are definitely our pharmacists or our pharmacist interns or residents. And evaluating safety of therapy as well. But then when it comes to affordability, I actually added my technician as well, because a lot of times you would think that the patients would tell their pharmacist if, you know, they're not taking certain medication because they just can't afford it. And a lot of times issues that were more social determinants of health that dealt with, you know, I'm too busy because I'm working all day and I don't get a 5-minute break, or I can't afford this because I have to pay such and such. A lot of those conversations many times came to light with the technicians during the intake or during the kind of exit of the visit. And the technicians were able to help us hone in on, you know, these patients can't really afford these medications. And then we had programs like patient assistance programs, et cetera, that the technicians were able to support and help patients with getting all that paper filled out, explaining the program, explaining that, you know, it doesn't harm them at all. It's just financial support and assistance and things around there. So and then assessing medication use and adherence. Again, of course, it's the pharmacist's role and responsibility. But there were times, and I think we can all attest to this, where patients, there's just this factor of a little bit of fear from, you know, the physician or the pharmacist in this case, and there's more comfortability with really letting the technician know, actually, I don't really take it. I told them I take it, but I don't. Or I told them I inject 3 times, but I inject once. So again, there's this collaboration. We're really able to work together to get patients' blood pressure under control. And then identifying med-related problems and evaluating the need for interventions, of course, is the pharmacist or intern. So you can see anything that requires the, you know, professional judgment of a pharmacist is left to the pharmacist. And then with number 3, developing and initiating the care plan, pretty much. The pharmacist is the one who would optimize the medication therapy, whether it's changing doses, initiating drug treatment, stopping drugs, or substituting drugs for the management of blood pressure, and really coming up with that patient-specific plan. And then they do provide the education to patients as well, but we always use our technicians to also kind of like re-educate, re-emphasize all the things that we've just explained to the patient. Many times even have the patient read back and explain what they think they're supposed to do between now and the next appointment. And really just, you know, reconfirm that education and monitoring, you know, interventions that will be carried out by the patient, and that the patient understands and is able to do the things that the pharmacist would like them to do. And then establishing parameters and timeframes for monitoring and follow-up. Those are all dictated, of course, by the pharmacist with respect to, you know, when are we going to follow up? When are we going to do a check-in with this patient to check on, you know, how they're doing with the recommendations we've made. And then lastly, we have the follow-up and medication monitoring piece. And this is really a combination of actual full follow-up visits where you're seeing the patient and getting, collecting all the information, but also check-in calls, which are I perceive them as just quick follow-ups. And this is where I know in my setting, and we've taught many to do the same, is using a technician to really support the check-in calls, because there's so many of them. And it's really where you're just calling to check on the recommendations that were made. How's it going? Were you able to make some of the diet changes? Were you able to, decrease your caffeine intake? Are you checking your blood pressures and writing them on your log? If so, what are your blood pressures? And, collecting that information and taking it down for the pharmacist, and then asking them, how are they taking their medications that, the pharmacist changed or updated or made any recommendations for. Another piece is following up with other providers that the technician helps us with, because, we may not be integrated in a setting where we have the autonomy to make the decisions right away and change blood pressure medications, et cetera. And there's a lot of recommending to the PCP office, and then kind of having to chase back and check, does the PCP agree? Can we make the change, et cetera? And again, the technician is vital in doing a lot of that, going back and forth, making calls, checking faxes to see if, the PCP has also agreed with the clinical recommendations that the pharmacist has made. And then just monitoring the care plan as needed. So that's just checking if they're, continuing to do those things. Modifying and refining. This is the one piece that obviously, requires the judgment of a pharmacist. And this is where the pharmacist will always see everything that the technician collects, and then come up with an assessment and plan and revision of kind of the care plan. And it goes in that cycle. And then documentation. We have, both the pharmacists, whether they're technicians, interns, residents, everyone would be documenting appropriately and accurately in an EHR, so that everything can be, in the system, available to all the teammates in the healthcare team. And the pharmacist will always review the notes and documentation that the technician has made to make sure, everything is accurate, everything is as they understood, and kind of does that final sign off on anything that has been documented by a technician. So lastly, this was that surveillance program I briefly mentioned before. And this is another area that we heavily rely on our technicians. So this is, once a patient has met their goals, for example, we have them with their blood pressure under control, we discharge them from our CMM programs, but we continue this surveillance program. And in order to do this, you really need technicians or other support staff that can help carry this out, because you're continuing to see current patients, and there's a growing number of patients that are getting discharged. And there's very objective questionnaires that are used for this, and basically the technician calls these patients who graduated from our program, and at first it's more frequent, it might be bi-monthly, and then as we're seeing that the next call is quarterly, the next is biannually, and then at a point it's annually, as long as the patient stays in control. And when the technician is calling for blood pressure, they're asking about the usual symptoms, they're asking them for their blood pressure reading. So even though they're discharged, we still have patients continue to check their blood pressure, because we want to make sure that it indeed stays at goal. And then if there's anything that's off, the pharmacist will always review this questionnaire. And if they notice, the numbers are creeping up, the numbers are, borderline getting, above goal, or have, actually gone over goal, then a modification and refinement of the care plan is done right away. Pharmacist interjects, comes up with a new plan, usually re-enrolls the patient, just to get them back on track. So the goal is really to remain closely integrated and ensure that we get people to goal and we keep them at goal. So these are just some examples of questionnaires and forms, because I know a lot of times there is a concern with, involving, other teammates in the team on doing things, on collecting information. We're worried they're going to lose some of the information or interpret it differently, et cetera. So in the pharmacy world, we try to have so many questionnaires that are very, yes, no questions, black and white, so that when we are trying to utilize our technicians and other support staff, we're sure that there isn't really that, maybe incorrect interpretation of a patient's response or anything of that sort. It's kind of, they're collecting the information that's clear. And then the pharmacist is reviewing all of that and coming up with an assessment and plan for the patient. And these are examples actually from different clinics. And when Fabiola speaks, she'll actually show you the one she uses for the surveillance program. And then lastly, I didn't talk about this first, but of course, clerical roles, that's, an easy one to kind of hand off to our technicians who do great with patient recruitment, marketing, scheduling, mailing the patients their med list. If this is being done remote, then there's a lot of mailing that happens with med lists, with logs, and then also faxing PCP offices and doing that piece that I touched upon a little bit. This is just a quick summary of everything we've spoke, so I won't even go through all this, but it's basically everything that the technician can assist with. And then this is an example in a visit, and we had gone through this in detail, but from scheduling the appointment, for example, and then the pharmacist and technician reviewing the patient, technician doing the intake with a questionnaire, the pharmacist reviewing that intake and the responses and coming up with their assessment and plan that then gets communicated to the patient, and with the support of the technician helping with the education, and then documentation by everyone on the team, and then all the clerical roles, including things like billing and reporting, and things of that sort. So with that, I want to give a few minutes to my technician. So this technician, like Cindy had mentioned, her name is Fabiola Barrera. I have had the pleasure of knowing her for over 10 years, working with her in different pharmacy settings, from an AmCare setting where we were in the clinic working together to manage blood pressure, diabetes, and much more, to this current setting that we're working in, which is a virtual pharmacist care center where she conducts comprehensive med management, helps support that under pharmacist supervision, and in that is a lot of blood pressure control for patients, as well as MTM, as well as conducting comprehensive med reviews, speaking to patients about adherence and why they're not taking certain medications, which also fall around blood pressure medications being, one of the top 3 categories that we focus on. So I just wanted to give her a few minutes to kind of talk about her experience. And with that, I'll hand it to you, Fabi.
Thank you. Hello, everyone. Nice to meet you all. During my role as part of the clinical pharmacy team during medication, during a hypertension management, I was one of the first that will go and greet the patient and bring them in. As soon as we had a room, I'll room them, and then we'll get straight to the medication reconciliation. I was taught how to properly conduct the medication reconciliation and properly document in the EHR. And so I went straight to it. Just, how are you taking your medication? Are there any new medications that you're taking? Are there any over-the-counter medications that you're taking? A lot of our population was Spanish-speaking patients. So a lot of them referred to natural products or productos naturales. And they really didn't see them as a form of medication, but that was something that will be cleared out by the pharmacist. So anything that they were taking or injecting, prescription or not prescription, we will always try to get that information from them. Not only that, but we will also, I will also go ahead and inquire about any issues that they may be having, including not maybe their pharmacy not dispensing their medication for whatever reason, maybe stopping their medication because maybe they weren't feeling so well. So that's the type of information that I will get a hold of on behalf of our clinical pharmacists, and then relay that towards the end of when I will be with the patient. Also, I was taught how to review pharmacist notes. I was taught how to review doctor's notes even in the EHR, just to look for those details of whether there has been any medication changes or maybe future procedures scheduled where there may be some changes to their medications or medications put on hold. So that was something that I will look for and just obtain that information on behalf of the clinical pharmacist. And then soon after the medication reconciliation, I would go ahead and start their vitaling. So I was properly trained and assessed during the USC Clinical Pharmacy Technician's certificate training on how to obtain this. So I would go ahead and proceed with checking their weight, get their BP or measure their BP, their blood pressure, get their pulse. And if there were also patients being monitored for diabetes, I will also get a finger stick. Next slide, thank you. And then, so once all of this information was obtained, I will go ahead and just go back to the pharmacist's office and talk to them a little bit about what we discussed, what I had discussed with the patient, whatever information was reported, the concerns, the issues, if any. And then the patient and the pharmacist would then meet for that assessment and that plan from the pharmacy. After, I would then meet with them one more time. So just before they were done with the clinical pharmacist visit, I will go back in and just reinforce education. So I will make sure that they had all of their questions answered. Just because sometimes it did happen, and it does happen where sometimes the patients do feel a little bit more comfortable just talking in an unofficial tone with me, and then their questions come up. Lots of questions tend to come up, but then again, we make sure that all of those are answered before they leave for the day. If there were any medication changes, any recommendations on diet changes, I will clarify all that for them and just reinforce. And then of course, if for our new patients, for example, I will definitely demonstrate proper technique on how to check their blood pressure to make sure that they know how to do that, and how to document that in their self-monitoring blood pressure log that we provide at every meeting. And then, of course, also asking them to make note of any diet changes, any new exercises that they plan to implement, just make note of that so that for their next meeting, that will be information that the pharmacist can have and may be able to aid during the visit with them. So the phone follow-up encounters, yes, they are great opportunities to follow up with them to make sure that they did make this medication changes, and then also just make sure how about their lifestyle, their diet changes, if there were any. And then also, not only this, but also take a moment and just ask if there has been any new medication changes. I know sometimes the medical group, the medical team from their doctors can also check in with them and recommend discontinuations or so dose changes, substitutions. So then it would be a good time for our clinical pharmacy team to obtain that information, and especially if there were any future appointments scheduled for some type of procedure where their medications are put on hold, then I will gather all that information on behalf of the clinical pharmacist and report back to her or him. And then the pharmacist will be able to provide a whole new assessment plan. And if needed, we can even postpone our appointment or reschedule our appointment with the clinical pharmacist just until after that procedure is completed, and so that we can see that the patient is back on their medication and be able to make sure that their blood pressure medication is working for them. Thank you. And then so finally, the surveillance program. So this is one of the in my opinion, one of the most rewarding responsibilities that I had, because it wasn't just there in the moment following up with the patient during the visits, but also just contacting them 3 months later, 6 months later. And it's always very nice to hear them, "Oh, hey, Fabiola, thank you so much for following up with me. I was expecting your call." So it's always good that for them to hear from our team. They're very, very grateful for the care that we have given them over the time. So during this time, these are the types of questions that I ask them. So I just follow up on regards to any side effects, any issues that they may have encountered with their medication, if they ever did stop their medication, and relay all of that information. Also, I was taught how to review some labs as well. So that's information that I also reviewed and obtained on behalf of the pharmacist. And then towards the end of the call, based on the outcome, it was decided whether to bring them back in for a re-enrollment in the hypertension program, or if they were fine to just follow up again at the 3-month mark again, or the 6-month mark. So yeah, this is basically what it would be from start to finish for a visit with the clinical pharmacy team, and my being part of it.
Thank you, Fabi. Thank you, Fabiola.
you.
So I love integrating Fabi and Steve does too, just because it's nice to hear from the technician, you know, what they feel like they're doing and how it makes them feel, and that connection that they have with our patients. I think it only affirms that we have to continue to grow this and expand it even more. So with that, I'll pass it on to Steve to help us kind of close up with next steps.
Yeah,
Before
thank
we
you
head
both.
off to Steve, I just want to ask Fabiola, if I may. First of all, Fabiola, thank you for bravely coming on to the Right Care Initiative University of Best Practices and sharing your amazing work. I have just a practical question that everyone on this call deals with, and that is when patients say, I don't want to take medication for hypertension. What do you tell them?
I do try to connect with them a little bit more on a personal level. I even at times, because my mother has the same problem. So I know that it helps to even just let them know X, Y, and Z reason as to why they should follow through. So I would say the number one thing is just try to help them understand that that it is a matter of their health. And it is either working with the clinical pharmacist, working with their doctor, working on their diet, and all that together can help with their medication management as well. So it's definitely a matter of connecting with them in a sense that they may feel like, okay, I can try it. And once I hear that, let the pharmacist know, all right, so she or he's ready to start. And then just try to make it as, as easy as for them as possible.
Yeah, I was going to add a quick thing to that, Fabiola, which I think you'll remember, is that a lot of times the patients would let Fabiola know something that they're worried about from the medication that they wouldn't let us know about. And it could be like a cultural myth that they think, this medication is going to damage my kidneys, or this medication is going to make me go blind. I saw a commercial on TV, and they would let her know, but they wouldn't let us know, because for us, they would just take the directions. So a lot of times it was like learning what their fear was, what is the reason behind them not wanting to take that medication, or getting addicted to that blood pressure medication, not wanting to rely on the medication. So learning to educate specifically to that fear and like that, why do they not want to take the medication?
Hattie, that was a great
Steve,
question.
I'm sorry that I interrupted your finale,
Oh, no.
so let me
No.
the baton back to you, Steve.
I'm glad you did, because you highlighted exactly what I wanted to say, which is I hope you all understand why we feel that pharmacy technicians in this expanded clinical capacity are really a disruptive innovation, right? They're so, at Fabiola is so fantastic at engaging and activating patients in ways that most of us can't do, especially because she's so culturally aligned, can speak the language, and so on. So, Fabiola to me is a role model in the space, and kind of leads us to what we're trying to do next year. We have, as I said, developed this certification program for clinical pharmacy technicians, and we continue to get a lot of interest from health systems and plans on training technicians. It isn't necessarily widespread, this practice, but more and more people are seeing and understanding that there's value in this. And so we do have one coming up soon. We're going to have them on a regular basis. And we're basically advertising pretty widely in terms of people that want to participate. We wanted to also expand on the community health worker-like services that our technicians are involved in. And I think you already heard, they're already doing much of it already. But we do have an interesting partnership coming up with the California Department of Public Health, their cardiovascular disease prevention program. Specifically, how do you know about this? It's a post-stroke comprehensive medication management demonstration project in the Inland Empire area with Inland Empire Health Plan and one of their regional hospitals. And this will give us a chance to partner with one of the larger CHW service providers in the state, and hopefully that opportunity to integrate some of those functions in with the clinical pharmacy technician. One of the challenges I think many of you know is funding for CHWs. And we're trying to leverage the fact that we need pharmacy techs and pharmacies. If we can have them provide a little support on the CHW side, a little support on the clinical pharmacy practice side, I think it could be a great win-win. We are, as I said, we do have a manuscript for our work in the CMMI Healthcare Innovation Award, but we're also conducting more rigorous analyses of the impact of clinical pharmacy technicians to build eventually that strong business case for expanding opportunities for pharmacy technicians. Rose had a question in the Q&A, and I want to address it briefly here. Her question was, how do you differentiate the value of pharmacy technicians versus other allied health that provide similar services? And I think this comes back to what I had said in the beginning, which is the part about the accuracy of medication reconciliation that pharmacy technicians are involved in. That really can't be understated. Remember, the pharmacy technicians, they touch medications, they know the nuances between drug names, doses, et cetera. It's really a very high level of understanding of medications, which just being very honest, it often is somehow, I don't want to say mishandled, but somehow things get mixed up in the system. And we, as Rita Shane's work at Cedars demonstrated, having technicians involved doesn't compromise quality at all. So I think that's one area that they're critically valued. I know we're out of time, so I want to thank everybody, especially my team, for doing most of this presentation. And thanks, Hattie, for the opportunity to share this work.
I think we do have a couple of questions from our leadership. Dr. Duddle, did you want to express your question directly?
Well, absolutely. Steve and to all of you presenters, Jessica and Fabiola, this is a home run. This is the next most important step, I believe, toward adherence. Steve, the only question is, do you have the evidence for improved adherence with this? And if you do, please let us know where the data is, because I think it was very impressive to me that when pharmacists stayed involved, the pressure stayed great. As soon as they went back to quote unquote usual care, without somebody contacting them, without solving their problems, without doing things that Fabiola can do, we lost them. So this, along with blister packs, are the only two things we have to add, and we'll get to 90%. Thank you.
Yeah. So true. We do have a manuscript that has some of that data. So that's where the data lies. And we will get you a copy as soon as we can get that thing published and done. But it's very close at this point.
Okay.
But yeah, I can agree with
I
you.
want to knit two things together. So Steve and Jim, I just want you to know that you two need to talk about this precision medicine with blister packs concept. Take it to the next level. Instead of a single poly pill for everybody, let's customize that treatment and then get it systematized through the pill packs. Different conversations. We don't talk together enough. But you two have some real change you're going to be making in the world. We also have Dr. Eveline Stock, cardiologist from UCSF, with us. Eveline, could you unmute yourself and weigh in?
So thank you, Hattie. This is a very, very important topic, and I am so glad we have the opportunity to discuss it at the Right Care Initiative. our technicians are fantastic, and I cannot understate the importance of how they help our patients stay on track. I mean, the median use of statins after prescribed is only 9 months in the United States. So it is a tragedy. And I'm hoping with these longer term new medications that are given every 6 months and precision medicine will help. But in the meantime, we need to use what we have. So thank you for doing this. And also the technicians are amazing and very valuable at getting our prior approvals. Without that, we're lost. So.
Yes, you do all the hard work. I couldn't agree with you more. Yeah, one thing I was mentioned, Jim, I'm glad you mentioned it, the blister packs. Yeah, I mean, they're obviously fantastic. I think one of the challenges we come up with from time to time is we refer patients who are already on blister packs, and they're in that middle of needing all kinds of medication adjustments, right? So it just becomes very complex. So we try not to blister pack them until they're obviously somewhere that they're stable. But in the meantime, the bridge becomes those pill boxes that we fill with them.
And absolutely agree. What I'm thinking of, though, is the long term.
Yep.
And in the long term, if you can make it, the directions are printed on the thing, it comes right, everything's together. You don't have to separate them into your boxes. All of those things give you that 20% better adherence. Absolutely. And it's virtually free. Right?
Absolutely. Yep. Okay. Agree.
But what you just demonstrated was the harder part. So thank you. This was really good to all of you.
Thank you.
So Bill, can you say, so thank you so much for this amazing work. And I was just thinking that in one of your slides, you show the pharmacist on the care team brief that we did together a few years ago. And I'm thinking we should update it to have it co-branded, Right Care Initiative and California Right Meds Collaborative, and give it greater reach, but update it with some of this great data. Could you elaborate a bit more on that Rita Shane finding?
Oh, yeah. This was actually a little while back where she conducted this study in the emergency room at Cedars-Sinai. As I shared before, there were 3 arms to her evaluation. It was pharmacy technician versus pharmacist versus sort of usual care without a pharmacist or tech, in conducting admission medication histories, and then determining whether there were any errors in terms of the admitting medication orders that were sort of subsequent to that history. And in that analysis, as you said, the tech and the pharmacist performed equally, meaning that in the end of the day, there were 80% fewer admitting medication order errors among pharmacists and technicians versus the usual care. So quite impressive. And I think the techs are not, Fabiola, you're not surprised, right? Because you guys are really good at getting extremely accurate medication histories of our patients.
So Dr. Baumer has a really important medication that he's going to be discussing as he leads a program in 2 weeks on Tuesday. I think it's the 27th. I might not have that memorized, but it's 2 weeks, Tuesday, 4 to 6 o'clock. Can you say a little bit of something about that medication so we make sure all the pharmacists that we have with us are aware of it? It's really quite a breakthrough.
Well, first of all, I want to thank the 3 speakers, Steve and Jessica and Fabiola, for tremendous important information that we need. There is no question in my mind that the pharmacy technician process that you have improves patient care and makes it easier for all the other healthcare professionals to work with the patient. No question, this is going to improve care. In fact, I would like to order 10 of them right now. So if you have a checkoff box, I need 10 right now for our clinic. Now, to get those 10 in our clinic, I have to show our hospital directors a business plan of how we're going to pay for it and where that is. So if the soonest we could get, let's say, a business plan outline of what this does for a healthcare system that I can then transfer to our administration, that would be extremely helpful, because yes, improving patient care is there. Yes, making it easier for all the others is very desirable. But unfortunately, our business leaders at our healthcare system want to see a business plan with dollars and cents and what this means at the end of the day or the end of the year for that. So the sooner we can get that type of information available, that's very important. And to follow up on, you want to answer that?
So sorry, yes, I wanted to say something. Something I'm asking you to help me with, Bill, and that's the state of California did add a new CHW benefit that started July of this year, something like $16 million available. And they haven't defined who exactly is eligible. So we were trying to figure out, is a clinical pharmacy technician eligible for that if they give those services? And
Yeah,
we're still working on that.
Yeah, and if you can get it reimbursable, then it's easier to show that business plan right away. So
Exactly.
yes,
Yep.
we'll keep working on that. I appreciate it. And to answer or to follow up on Hetty's question, in 2 weeks, or on the 27th, which is a Tuesday afternoon, we're going to discuss some of the innovations that have taken place in obstruction causing left ventricular hypertrophy. Now, today, hypertension causes left ventricular hypertrophy and leads not just to hypertension, but complications of it. And hypertrophy can lead to increased myocardial infarction, increased stroke, and increased death. So this is certainly one aspect of treating hypertension. The other aspect is obstructions to the left ventricular outflow that lead to LV hypertrophy by itself. Those relate to a couple of entities, or 5 or 6. We're going to focus at least on 2 of them. One is aortic stenosis, where we can today replace the aortic valve and eliminate or reduce that left ventricular hypertrophy and the complications from it. We have very innovative ways of doing it with transcutaneous aortic valve interventions, which are catheters. And in literally 10 minutes, we can replace your aortic valve while you're awake and talking to us at the same time. You go home the same day. So innovative ways of really affecting that. And the last is in hypertrophic obstructive cardiomyopathy. We have interventions, but today we also have additional medicines called myosin inhibitors. These are the novel first-time use of a myosin inhibitor to give us medical therapy to reduce or relieve completely the obstruction from hypertrophic obstructive cardiomyopathy, things that in the past required some medicines, but unfortunately in 40% of the cases that was not enough, and patients had to go to the operating room or to the interventional lab for it. We now can reduce perhaps 80% of those who needed an intervention with just a simple medicine twice a day for that, a myosin inhibitor. New treatment that has been and is now FDA approved for that use. So we'll be discussing that at that time. So that's what we're going forward in the future. And we certainly want to thank all our participants today. I have one last question for Steve, who is a dean at USC. And as a dean at USC, I want to know, were you the one that approved the transfer of USC from the Pac-12 to the Big Ten? Are you the culprit responsible? Because now I see that you're trying to join Mike Dolan in the Big Ten with Wisconsin. And I want to know if it was your decision or vote.
Well, I wish I was at that level. I'm an associate dean, so that was decided about 10 layers above me. So no, purely a business decision, as you all know. More to come, but we'll see.
All right. Well, thank you, everyone. We and great participation today and to great speakers. Thank you very much. And we'll see you all in 2 weeks.
Thank you.
Thanks,
And-
everybody.